All right, before moving on to the objective assessment or objective examination, I'm apologize if you can hear it, but my cat l- is lying down right next to the microphone purring, so hopefully it's not going to be distracted. So the components of the objective assessment are the observations, the range of motion, strength, special tests, palpation, and functional tests. They are in order of least painful to most painful, and that's how they should be uh, uh, performed in, because you don't want to create pain that will affect the next test you want to do. But also within each of these components, you also want to go from the least painful to the most painful. So, for example, if you are assessing a patient that has a ankle sprain and they said that they injured themselves while doing inversion, well, you want to test all the inversion at the end of each step, because you don't want it to influence the range of motion in other direction, or the strength in other direction. So you have the most uh, clear view of what the current situation is. So your observation, here's what it should include. You should look to see if there's any swelling. Is there any deformity, discoloration, redness? Is there, and then you're going to go through a gait assessment, like a general gait assessment. Can they walk? Do they have compensation? What are those compensations? Um, their posture, is the posture affected by the condition, or does the posture possibly have exacerbated the risk of having this condition? So, for example, if you have bad cervical thoracic posture, well, it increases your risk of having shoulder injuries in some sports. Are they bracing or protecting their injured limb? Are they using walking aids, a sling? So everything you can observe with your eyes is under observation. Then you're going to move on to assessing the range of motion. You can do it active and passive. Active is when the patient is moving their limb themselves without any help. And passive is when you do it without any help of the patient. Um, we can use a goniometer, which is what you see in the picture here, to measure the joint angle, um, which is what we typically do in a clinic. On the sideline, we don't, or as part of a sport assessment, we don't. And then we can compare to the other side, or to what the normal ranges are. For strength, there's two ways to do it. So you could do resisted range of motion, in which you test that you have a general sense of the strength in a motion. So, for example, you can test the strength in shoulder flexion, in shoulder abduction, as opposed to testing the strength of the anterior deltoid, which, for example, you would need to apply a resistance to the shoulder, um, so that the patient contracts the muscle while doing shoulder abduction and horizontal adduction, which combining movement. That would be specific manual muscle testing. In this lab, we're only going to do resisted range of motion, so that we have time to have a full understanding of all the peripheral uh, joints. You can grade the strength. So if they if you start with range of motion and they do active and they can do the full range of motion against gravity, they automatically get a 3, because that's what a 3 is. Now, after that, you put them into mid-range or neutral position, and then you apply a resistance to that movement. If they can resist the same resistance on both sides, which should be a lot. You're actively trying to break the isometric strength of their joint. So if you can't, then it's a 5. But if you can and they're both equal, then it's also a 5. A 4 would be that they can withstand some resistance, but not as much as the other side. So that's a 4. So now what happens if they can't do the full range of motion against gravity? Then you will put them in a position, preferably on a treatment table that can stabilize the limb that needs to move, and ask them to do the movement not against gravity. So, for example, if they're trying to do knee extension, you would put them lying on their side so that they can do knee flexion and extension while not against gravity. And if they can do the full range of motion like this, that's a 2. Now, if they can't, but when you palpate, you still feel the muscle being able to contract, that's a 1. And now, if while they attempt to move, nothing happens and you can't feel anything, that's a 0. It's very uncommon in sports that they will have a 0. Typically, it's a 3 and above, unless they have a full rupture of their muscle. And then you move on to the special tests. With special tests, your objective is to determine specifically which structure was injured. The special tests are there to either confirm or rule out some of your hypotheses. So it can be a stress test for the ligamentar capsule, a flexibility test, a neurological vascular test. There are multiple special tests for every joint, and some tests, some structure have multiple tests as well. You will choose the most appropriate test based on the patient's history. So if the mechanism of injury leads you to think it's a ligamentous injury, then you're going to test the ligaments. Special tests are not all created equally. Some of them, although used frequently, are actually not really good at ruling in or ruling out pathology. So what I want you to know is what criteria we need to use to evaluate whether special tests are appropriate to use or not. The first one is sensitivity. Sensitivity is the ability of a test to identify patients with pathology of interest. So if a test has a low sensitivity, which means it's not really good at identifying patient that has the pathology, then you'll have high rates of false negative. Sensitivity is very useful so that when you have a test that is negative on a special test that has a high sensitivity, it's very useful to rule out a pathology. For example, if you have a test that is really, really good at identifying patient with a pathology, when it's negative, you can be sure that it's a true negative. But if it's a positive, it means nothing. So high sensitivity means it's useful to rule out, and to remember, you can use the acronym SNOUT. So SN for sensitivity and OUT for ruling out. Specificity is the opposite. It's the ability to detect a patient that do not have the pathology. So if you have low specificity, you're going to have high rates of false positive results. A positive result on a highly specific test is useful to rule in a pathology. So if the test is really good at determining the patient doesn't have the pathology and it's positive, then you can almost be sure that the person has the pathology that you are thinking of. And to remember it, you can use the acronym SPIN, SP for specificity and N for ruling it. And what kind of measure are we accepting in terms of what is the lowest sensitivity and specificity we should look for in a special test? Well, above 80% is acceptable. The closer you are to 100%, the better. But ideally, you want something above 90% or 0.9, depending on how they report it in the scientific paper you're reading. Now you can see that it was quite complicated to try to figure out if sensitivity and specificity was equal to ruling out or ruling out. So we have a measure that combines both with likelihood ratios. So you have positive and negative likelihood ratios. A positive likelihood ratio is a proportion of individual who had a positive test and actually had the pathology. It is calculated as the sensitivity divided by 1 minus the specificity. And when you have a positive test on a test that has a high positive likelihood ratio, then you can have a high confidence that you can rule in the pathology. The negative likelihood ratio, again, the opposite. So it's a proportion of individuals who tested negative on the test and actually didn't have the pathology. It's calculated as 1 minus the sensitivity divided by the specificity. And with these tests, you can have a high confidence that you can rule out a pathology. So for positive likelihood ratio, you want the highest number possible. If it's above 10, then you can be really confident that a positive test is actually an indication that the pathology is present. For likelihood ratio, you want the lowest possible negative likelihood ratio. If it's under 0.1, then you can have high confidence that your negative test is actually negative. You can accept anything in the light yellow, and as you move lower on this table, the least confident you can be in your actual confirmation of your hypotheses. That doesn't mean that your hypothesis doesn't mean anything. That just means, well, does it make sense based on the history and the examination and the rest of the examination? That's what it is. And if so, then you can still use your experience into having that clinical impression. That doesn't mean that you can't use that clinical impression because it doesn't have a good test for it. You just have to be a little less sure and confidence in yourself that you could not confirm or deny that hypothesis. Then you move on to palpation, which is used to pinpoint the exact structure that's injured, and also to detect any abnormal sensation under your fingers. So is there any crepitus, so it feels like crackly under your fingers, or any other abnormalities, such as like a gap or a defect. And as you can imagine, it means you need to know your anatomy very well. So in the middle, you have a nice picture of where the ligaments are from the outside of the ankle and where you should palpate them. So I'm going to ask you this. Do you know which muscle the clinician on the left is palpating? And do you know which bone of the wrist the clinician on the right is palpating? You should know both of these answers. If the patient is well enough to do so, you could do functional tests. If there's a lot of swelling, a lot of pain, and really you don't expect the patient to have a high level of function, then you can delay your assessment of functional tests. That is to patients that basically you're still determining how you should modify their activities. for people that have a lot of swelling and stuff, you will limit their activities a lot. For people that have somewhat a high functioning of like body part, then you might want to do them. You want, so for lower extremity, well, they should be, you should be able to know, can they walk? And then for athletes, jogging, sprinting forward or backwards, changing direction, jumping, squatting, doing lunge, and any sport specific activities that you deem necessary. In activity of upper extremity, can they toss, can they hit, can they pitch, can they reach up, can they do the plank and put be weight bearing on their upper extremity, and any sport specific activity. After you've done your assessment, well, hopefully you can now have confirmed or ruled out some of your hypotheses, and you will have one that will be dominant. And that is your clinical impression. So that is what you think the structure, the problem is. What is the pathology? Is it a sprain, a strain of what structure? This is what your clinical impression is.